Our next speaker is Dr. Maggie Westby, a Senior Research Associate at the NIHR Applied Research Collaboration West and University of Bristol. Maggie brings a wealth of experience to the webinar as a systematic reviewer and methodologist, and her recent research interests have included virtual wards. Her presentation focuses on virtual wards for people with frailty. Over to you, Dr. Westby. Thank you.
Thank you, and good afternoon, everybody. As Candace has just said, I'm going to be focusing on virtual wards for people with frailty, thanks to my colleagues in ArcWest. Next slide, please. So a bit of background to do with frailty and virtual wards. So a minor event such as a UTI can trigger a frailty crisis, thinking about delirium, sudden immobility, severe falls, from which the patient doesn't fully recover. And that's leading to hospital admissions and dependency. This is described graphically in the orange picture. And on top of that, we have the prevalence of severe frailty is increasing with time, and particularly so in older people. And that's leading to a crisis for the health service. So we asked the question, do virtual wards help? And our research aims were to identify virtual ward models in the UK, to understand how and why they work rather than whether they work. And this led to us doing a realist review, and we hoped that it would inform policy. Next slide, please. So some different definitions at the outset from the literature. Virtual wards, care is provided to the patient in their own home. A multidisciplinary team makes decisions and plans care remotely from the patient, and the MDT oversees patient care. And as Graham was saying earlier, a hospital at home is defined as coordinated multidisciplinary care in the home for people who would otherwise be admitted to hospital. And we can see that there is some overlap between virtual wards and hospital at home, but they're not identical. Next slide, please. So the findings from this realist review. So in terms of the types of virtual ward, we identified two main types of virtual ward in the UK. And they were a longer term virtual ward where the patients were people at high risk of a frailty crisis, and they were offered proactive care to prevent a crisis, and short-term virtual wards for people who are already in a crisis and they received acute reactive care. And this is the model that NHS England has introduced. So looking at how frailty virtual wards can work better, and that is really the context of the NHS England rollout. How not do they work, but how can they work better? So the themes were having some building blocks, which included common standards agreements, information sharing, appropriate MDT composition, MDT meetings, or otherwise known as virtual ward rounds, and a virtual ward coordinator. And then the second theme was how virtual wards deliver frailty management effectively. And the third theme was patient and caregiver involvement and empowerment. And we are also identifying mechanisms about how these things could work. And they included having a team of teams, trust in shared goals, motivation, starting small. You know, it's the people that make for the change rather than the interventions themselves. And also emerging was some understanding, which we have summarized as the need for a whole system approach, and also the need for proactive care to reduce crises. Next slide, please. So a bit more about this, and this is some of the sort of disadvantages that are coming through, and not to detract from the advantages of virtual wards, but so reactive care virtual wards are not usually 24/7, and caregivers may not cope with frailty crises. And also short-term wards, they need post-discharge proactive care to prevent further crises. But the findings were that discharge to the GP can be uncoordinated and unpredictable. And we're also finding that virtual wards should be integrated into frailty management. Next slide, please. So talking of which, frailty management as a whole system approach, it's big in virtual wards in the blue ring. It's a small part, and also thinking about how sort of recent developments with frailty hubs and everything under one roof. Next slide, please. So proactive care, what's the good about that? So severe frailty, as I was saying before, leads to crisis from which people are treated but don't fully recover, putting them more at risk of further crisis, and it goes round and round and round, leading to risk of readmission to hospital or the virtual wards, with on top of increasing frailty prevalence, not a very good sort of outlook, and worst case, leading to potential overload of virtual wards, which is not sustainable. What can we do about that? Well, to interrupt the vicious circle with proactive care. Next slide, please. So recommendations that were coming out of this review. So implementing the improvements that I was talking about earlier, and for sustainability, offering proactive care to prevent high-risk patients reaching a crisis, and then having a whole system approach to virtual wards, which requires effective patient selection and discharge, and in terms of frailty, identifying patients at high risk and offering them proactive care. And that might be in the virtual ward itself, under GP schemes or in one of these frailty hubs, and that would be alongside people who are already having a frailty crisis. And we also identified opportunities for integrated frailty services. So virtual wards, as I said before, are a part, and opportunities to have the high-risk group and those in crisis in the same virtual ward or in a frailty hub with the same staff, needing good communication, caregiver involvement, and systems in place. Next slide, please. And that's further information, particularly policy briefing. Thank you.